Other tests that we need to do in pregnancy is to check the mother for syphilis, hepatitis B, and HIV infection. Also, full blood count is also done, and hemoglobinopathies, they are also done. Two ultrasound scans are usually offered during the course of an uncomplicated pregnancy. One is a dating scan that is offered between 10 to 13 weeks, and a fetal anomaly scan that is offered at 18 to 20 weeks. Along with folic acid, 400 microgram per day for 12 weeks, we need to give vitamin D, 10 micrograms per day throughout pregnancy. Now, chickenpox in pregnancy, how we are going to manage chickenpox in pregnancy? The management is very simple. We have two scenarios. One is that if a pregnant lady is exposed to chickenpox, and the other scenario is that a pregnant lady developed chickenpox. The management of both of these conditions is different. If someone is exposed to chickenpox and she has not developed the disease yet, then we can prevent the disease by giving immunoglobulins or antibodies from the outside that are known as VZIV, varicella zoster immunoglobulins. Now, if a female is exposed to chickenpox virus, remember that the infectivity period of chickenpox virus is 2 days before the appearance of the rash and 5 days after the appearance of the rash. 2 days before the appearance of the rash and 5 days after the appearance of the rash. This is the infectivity period for adults. So if a female is exposed to chickenpox virus, then we need to give immunoglobulins. But before giving immunoglobulins, we need to check her immunity. We need to see if she has developed any natural antibodies or immunoglobulins against the chickenpox virus due to past infections. So the first step that you do is to check antibodies. Hello everyone, I'm back. Sorry for the temporary interruption. So I was telling you about how to manage a lady with chickenpox exposure. So if she is exposed to chickenpox, then we need to give immunoglobulins. But before giving immunoglobulins, we need to check if she has developed any uh, natural immunoglobulins due to past infection. So if after checking the immunity, the female is not immunized and she is less than 20 weeks gestation, then we'll give varicella zoster immunoglobulins. But if more than 20 weeks gestation, then we'll give acyclovir. Remember that acyclovir is only given to the patient with who develop chickenpox, either they are pregnant or if they are immunocompromised. But this is the only case in which we are giving acyclovir uh, for the prophylaxis or for prevention. And that is if a woman who is exposed to chickenpox and is not immunized and is more than 20 weeks gestation. And if a pregnant lady develops chickenpox, then we will administer acyclovir. We need to treat chickenpox during pregnancy, and because if it's not treated, then it can lead to fetal varicella syndrome, which can include limb defects, eye defects, and microcephaly. Remember that we will give varicella zoster immunoglobulins to an exposed lady if she is less than 20 weeks of gestation. Why we give varicella zoster immunoglobulins if it's less than 20 weeks gestation? Because if we do not give immunoglobulins, then the risk of getting or the chances of getting fetal varicella syndrome is high. And after 20 weeks, the chances are very less. That's why we will give immunoglobulins if less than 20 weeks gestation and she is exposed, and acyclovir if more than 20 weeks of gestation. So one indication for varicella zoster immunoglobulins is uh, pregnancy, a pregnant woman less than 20 weeks of gestation. The other indication is a neonate who is exposed to chickenpox. And what is the exposure period for a neonate? Remember that the exposure period for neonate is 7 days before the delivery and 7 days after the delivery. For adults, the exposure period is 2 days before the appearance of the rash and 5 days after the appearance of the rash. And for neonates, it is 7 days before the delivery and 7 days after the delivery. This is a second indication. And a third indication is we give immunoglobulins to those patients who are immunocompromised. So pregnancy, neonates, and immunocompromised patients such as who are taking steroids or someone who has an immunodeficiency disorder. These three categories need to receive varicella zoster immunoglobulins if they are exposed to varicella zoster virus. For adults, the exposure period is 2 days before the appearance of the rash and 5 days after the appearance of the rash. And for neonates, it is 7 days before the delivery and 7 days after the delivery. Similarly, if a pregnant woman or an immunocompromised person they develop chickenpox, then we'll give acyclovir and not varicella zoster immunoglobulins, because varicella zoster immunoglobulins, they are for the prevention. So this was all about chickenpox in pregnancy. I hope it's clear to everyone. Is there any question? Next topic is urinary tract infection in pregnancy. The two most commonly asked about antibiotics in pregnancy are trimethoprim and nitropurentine. Both of them can be used for the treatment of UTIs in pregnancy. Trimethoprim is an antifolate drug, so it need to be avoided in the first trimester of pregnancy because it can cause neural tube defect. But if we don't have any other option and we must use trimethoprim, then it can be used along with 5 milligram of folic acid. And nitropurentine should not be used near term because of risk of neonatal hemolysis. So near term nitropurentine should be avoided, and in the first trimester trimethoprim should be avoided. Other drugs that can be used for UTIs in pregnancy include amoxicillin, but if a person is allergic to or resistant to amoxicillin, then we can use cephalexin. So you can pick nitropurentine if the patient has UTI, but do not pick nitropurentine if she is at term. Term is basically usually 37 weeks of gestation. If no nitropurentine is given in the option, then we can pick cephalexin, and if both of them are not given, then we can also pick amoxicillin. Macrolides such as erythromycins are also safe during pregnancy, so they can also be used. Ciprofloxacin is used for the treatment of UTI, upper UTI in general population, but it is avoided during pregnancy because of risk of arthropathy. So nitropurentine is usually avoided near term. What is near term? 1 week before and 1 week after the estimated date of delivery. So you should avoid nitropurentine in this duration of time. So this was a short summary of UTI in pregnancy. Now constipation in pregnancy. So the three safest laxatives that are safe in pregnancy and that we should start with in pregnancy if the female present to you with constipation, they are espeol husk and lactulose as the second line, and Sina or stimulant laxative is the third line. In normal population, uh, after espeol husk, we try Sina or stimulant laxative, but in pregnancy, because Sina can cause abdominal discomfort, so that's why it is tried after lactulose. Now, dealing with constipation in general population, if we discussed it already in the gastroenterology chapter, but we'll have a short revision. Impacted stool phosphatemia in a nursing home patient who present to you with constipation and there is impacted stool on examination, we use phosphatemia. And in young or healthy patient with no comorbidities, then impacted stool, then we try glycerol suppositories. For hard stool, we can use stool softeners, stool softeners such as glycerol. Again, the order of constipation intervention for constipation in general are as follow: high fiber, Sina and lactulose. While in pregnancy, it is high fiber, lactulose, and then Sina. Prokinetic agents, domperidone, metoclopramide, and erythromycin, they can also be added. Dendron can also be added. We have already discussed when to give varicella zoster immunoglobulins. If an immunocompromised, a pregnant or a newborn is exposed to varicella zoster, then immunoglobulins. And if immunocompromised or pregnant develop chickenpox, then we need to give acyclovir. Now, some points about termination of pregnancy. Remember that termination of pregnancy is legal before the 24-week of gestation in the UK, but this limit does not apply in cases where it is necessary to save the life of the woman, or there is evidence of extreme fetal abnormality, or there is a risk of serious physical or mental injury to the woman. So this is the case, then this limit will not apply in any of these cases. Usually, two registered medical practitioners must sign a legal document before terminating a pregnancy, but in emergency situation, only one document is required, and only a registered medical practitioner can perform the abortion. Abortion can be done medically if gestation is less than 9 weeks. Medical abortion is done through mifepristone and prostaglandins. Mifepristone is given first, and then 48 hours later, prostaglandins are given. And if the pregnancy is more than 9 weeks but less than 13 weeks, then surgical dilatation and suction of the uterine content is done. And for more than 15 weeks, surgical dilatation and evacuation, or medical abortion through drugs such as oxytocin or even mifepristone can be tried to induce mini labor. So for less than 9 weeks, mifepristone and prostaglandin. For less than 13 weeks, surgical dilatation and evacuation. And for more than 15 weeks, surgical dilatation and evacuation, or late medical abortion by inducing mini labor. Then there are some questions related to ethics. If the normal age of, the legal age of giving consent in UK is 16 years. But if the patient is, if the person is less than 16-year-old, but he understands the consequences of the procedures, then he can also give consent. Now some points about tamoxifen. Tamoxifen is used in the breast cancer treatment, and we have discussed it in the gynecology that tamoxifen has dual action. On the breast, it acts as an anti-estrogen, while in the endometrium, it acts as an estrogen and agonist. So it increases the risk of endometrial carcinoma, but it suppresses the breast carcinoma. Because it increases the risk of endometrial carcinoma. So in a patient who is taking tamoxifen, the most important alarming symptom should be vaginal bleeding. So a patient who is on tamoxifen and she develops abnormal vaginal bleeding, then you will suspect endometrial carcinoma. So remember this point. Now the last topic, management of genital herpes in pregnancy. We discussed the management of chickenpox in pregnancy. Now management of genital herpes in pregnancy. If the female has got the infection for the first time and she is in the first or second trimester of pregnancy, then we will give oral acyclovir. Remember, oral acyclovir and not IV. Oral acyclovir 400 milligram TID for 5 days, and then suppressive acyclovir 400 milligram TID from the week 36 of gestation until delivery. So very simple. If a female develops genital herpes and this is her first time and she is in first or second trimester of pregnancy, then 400 milligram acyclovir for 5 days and then 400 milligram TID from 36 week of gestation until delivery. And if she develops genital herpes in the third trimester for the first time, then again this therapy will be given, 400 milligram TID for 5 days and 400 milligram from 36 week of gestation until delivery. But the difference between first and second trimester management and third trimester management is that in first and second trimester management, along with acyclovir, vaginal delivery is done, and in third trimester, along with acyclovir, cesarean section is done. So if a female develops genital herpes during the third trimester of pregnancy, we will give 400 milligram for 5 days and then 400 milligram for 36 weeks of gestation. And the baby will be delivered through cesarean section. And in first and second trimester, the baby will be delivered through vaginal delivery. This was the management if the patient has got genital herpes for the first time. But if the genital herpes is recurrent, for recurrent genital herpes, the mode of delivery is vaginal delivery. Other treatment is same. Only in third trimester, the preferred method of delivery along with acyclovir is cesarean section, while in case of first and second trimester and if the infection is recurrent, the mode of delivery is vaginal delivery. And if the genital herpes is recurrent, then we do not need to give oral acyclovir 400 milligram for 5 days. We will start the oral acyclovir from 36 week of gestation until delivery. So this was all about genital herpes, and this was all about obstetrics. We are done with gynae and obs. If somebody has any question, then they can ask.